Good evening, everyone. Thank you for attending the present session as well. So, myself, Dr. Deepak, as introduced, and would be glad to take a session on the present topic, rheumatology. I'm sure you're all good students, obviously. So, this present focus is on basically some of the exam-oriented questions, like we'll be discussing some questions and the answers to it and the reasonable explanation for it. And at any point of time, if you have any doubt, you can just put a message in the chat box so that we can discuss at the end of it. Okay. So proceeding to the present session. So this is a 21-year-old gentleman who presents to the dermatology clinic with red scaly plaques on the cheek, forehead, and sides of the neck. So I just kept a pictorial depiction. On close inspection of the patches, plugging of some hair follicles with keratin and diminution of the skin was noted. So which one of the following is the most likely diagnosis? So any one of you can answer it. I just thought it will be an interactive session. Yeah. So Dr. Priya Ranjan has answered E. So all of you agree with it. So what is the justification for the answer E is basically discoid lupus erythematosus. The answer is definitely correct, which is discoid lupus erythematosus. In a discoid lupus, the lesions are discrete, often erythematous. They're covered by the scales that extend into the dilated hair follicles. These lesions are mostly occur on the face, scalp, pinnae behind the ears and on the neck. They can exist in the areas not exposed to the sun as well. Okay. So these lesions will usually progress. If you have a progressive lesion, you can have an active indurated erythema at the periphery. In the discoid lupus, especially, there's the central atrophic scarring is the classical characteristic of the discoid lupus erythematosus. If you don't treat it, they may go on to permanent scarring and with the alopecia, resulting alopecia. And these people with widespread disease are at increased risk of developing systemic lupus erythematosus. What is the treatment for it? The treatment is local treatment, fluorescein cream, hydrocortisone, and acitretin are the topical options. So, whereas the other options which are given in the question are eczema. Eczema usually manifests as a dryness, and there is a secondary lichenification, which is a more diffuse process, as against this case where you have a discrete plaques. Psoriasis can also present with inflamed lesions, but usually they are covered with silvery white scales. And the other classical features of psoriasis, obviously, you should read about it. The other differential diagnosis, polymorphic light eruptions. They're characterized by recurrent, abnormal, delayed reactions to the sunlight. Okay. So these terms are very important for you. Delayed reaction to the sunlight as well as their recurrent. I'll show you a picture of these polymorphic light eruptions, PMLE. And sometimes it may progress into erythema multiforme like lesions as well, especially in the sunlight exposed areas. Almost all of the time, this PMLE occurs on the sun exposed surfaces. There is other differential diagnosis is porphyria cutaneous tartar. You can have a primary deficiency or secondary deficiency of this particular enzyme, uroporphinogen decarboxylase. How is the classical presentation? The commonest symptom is cutaneous fragility and blistering of the sun exposed skin. Again, you can see here the PMLE and the PCT, both of them occur in the sun exposed skin. And in the porphyria, as you know, there might be a urine discoloration as well. So these are the classical presentations. So as you can see, the down one is the porphyria cutaneous tartar. You can see they are occurring in the sun exposed areas, as well as you can see the blistering of the lesions as well. Whereas the right top part is the polymorphic light eruptions. Okay. So polymorphic light eruptions, as you can see, they are occurring again in this zone where the sun area will be there. And these come as showers, and again they'll disappearing in the showers, and they'll occur recurrently. So where the left top corner shows you an eczematous lesion, where you have a secondary lichenification in the further down the place. Okay. So the next second question. So which one of the following pathological condition is closely related to the psoriasis? So I have just attached one of the picture just to depict the present lesion. So what is the answer for it? Any one of you can answer in the chat box. Just hold for 10 seconds and then we'll again start the discussion. what is the pathological condition with the psoriasis? So this picture basically shows you a Koebner's phenomenon, okay, where you have an injury. So there will be a secondary insult there, and there will be this reddish induration discoloration. So this is called as Koebner's phenomenon. So the answer is psoriasis is associated with the Koebner's phenomenon. See, always remember when you have a question and you have 5 options, you should always know each option thoroughly. Okay, it's like actually you're reading five proper concepts. So it should always be a concept-oriented reading rather than just remembering the answer to the question. So in that case, if you prepare in that fashion, at the end of the like your for your main exam, in whatever the way they frame the question, you will be able to answer the question. Okay. So Dr. Priya, you are correct. I think the answer A is the correct one. So what is the explanation for it? So psoriasis, as you know, it's a chronic relapsing inflammatory disorder. The classical features are always like as we discussed in the previous question, they come as erythematous, sharply demarcated papules and rounded plaques covered by the silvery scales. And how do you diagnose? The diagnosis most of the time is a clinical diagnosis. And sometimes when you have a differential diagnosis, sometimes in the atypical presentation of the psoriasis, you can go with a skin biopsy. Okay. So this particular question is based on the Koebner's phenomena. This is basically the new lesions. Whenever you have an injury or trauma, in the new sites of injury, you will have a new lesions. Okay. And they come after 1 to 2 weeks after the skin damage. So this is the particular question. Whereas what you need to always remember about the other options as well. Okay. Psoriasis can be associated with an anterior uveitis, but like in this case, optic neuritis is not the feature of psoriasis. Rather than that, actually, the anterior uveitis is the classical feature of psoriasis. Coming to the other option, the option B, angular stomatitis. What is angular stomatitis? Basically, you know, the fissuring of the skin edges into the angle of mouth. The most common cause is Candida infection, but it is also associated with allergies, seborrheic dermatitis, vitamin B deficiencies, as well as iron deficiency. It is not described with the psoriasis like this, like in this question. Other questions may be framed on the psoriasis, like they may frame on the psoriatic nails and the arthritis, or maybe in atypical manifestations of the psoriasis as well. But like asked in this question, it is very rare for the psoriasis to go into a scarring alopecia. Okay, so that is not the answer here. Whereas up to 30% of the patients with especially the chronic psoriasis, chronic plaque psoriasis can be affected with an arthropathy as well. And always in an MRCP, whether in a part 1 or part 2 or maybe in the final part of MRCP, psoriatic arthropathy is one of the very classical questions which will be given to you. And you need to always identify the psoriatic arthritis, psoriatic nails by the nail pitting. The examiner will obviously expect you to identify those nails. Okay. So in the psoriasis, usually they present with mild distal interpharyngeal involvement. Again, remember, you need to differentiate various types of arthropathies, arthritis based on whether they're involving which joints. Are they involving distal interphalangeal joints? Are they involving proximal interphalangeal joints? What is the level of erosion? All these questions will be expected of you. Okay. So in this case, the psoriasis can cause mild involvement to at the extreme, it can involve a severe mutilant arthritis as well. Okay. So what is the cause for psoriasis? Exact causes are not known, but it is known to have a strong genetic basis. Usually the Caucasian populations are more common than us to be involved. And it seems to have 2 peaks of incidence. Okay, one is in the younger group, like from 16 to 22 years, and which is the second modal incidence is between the 57 to 60 years. And both males and females are equally affected. And factors like infection, stress, medication, all of them may exacerbate or may precipitate a psoriatic exacerbation. And you may are expected to remember these drugs like lithium, gold salts, beta blockers, and antimalarials like chloroquine. They're all known to exacerbate the baseline psoriasis. Okay. So when you're asked a question about the psoriasis, you are obviously expected to know the other features of the psoriasis as well. Okay. So the answer here is A, Koepner's phenomenon. Coming to the third question, 36-year-old lady presents to a ortho clinic for follow-up with a right-sided Colles fracture. This fracture occurred following a mechanical fall in the drawing room at home. So as you can understand, it seems to be a very minor fall, but there seems to be a fracture here. Okay, and especially it's not in the very elderly age group as well. It seems to be in a pretty younger group of 36-year-old lady. The orthopedic consultant is doubtful because there seems to be very low velocity mechanism of injury, but at the same time, it's not correlating with the amount of fracture. Okay, so which of the following measurements would indicate a diagnosis of osteoporosis? Are you going to apply a T-score or Z-score? And if you're going to apply one score, which is the cutoff you have? What is the answer for this? You will have 10 seconds. So this is expected of you because here the questions you are expected to know is, one is a type of fractures. How do you differentiate the pathological fractures with a normal fracture? Second point is how do you interpret the bone mineral density BMD test, and what are your cutoffs and what are the guidelines as well. And obviously, once you know this, the extrapolation of these questions will be treatment of osteoporosis and the fractures. So going forward to the answer is C. Okay, so here the answer is a T-score of minus 2.5. Yes, Dr. Jaydeep, you are correct. So the answer is T-score minus 2.5. Okay, so what is the explanation for it? As I told you, before going to the core of the question, you are expected to know the pathological, what are the risk factors for low bone marrow density in the premenopausal women. Obviously, we know perimenopausal and the postmenopausal women, we know the risk factors, whereas the deficiencies of the hormones itself is a major risk factor. So there are two types of scoring system. One is a T-score and second is a Z-score. Okay, T-score is where the patient's BMD is compared with a healthy young adult. Okay, whereas Z-score is where the individual's BMD is compared with the population of the peer groups. Okay, so the Z-score is more for population studies and for the epidemiology, whereas the T-score is for the specific purpose of comparing one particular patient's BMD with a comparable healthy young adults. Okay, so in this case, obviously, because he's asking about that particular patient, so you're going to use the T-score. Okay, so once you know that, how do you classify the osteoporosis? You can have a severe the osteopenia, which is basically T-score between -1 to -2.5. Okay, whereas the severe osteoporosis is where the T-score is less than or equal to -2.5, but at the same time there will be a fracture. Okay, so whereas this patient falls in more or less around that period, whereas osteoporosis is the hip bone marrow density, T-score is minus or equal to -2.5, but there is no fracture. Okay, so please remember this classification. Basically, the T-scores. What is normal? Obviously, normal is where your T-score is more than or equal to -1, which is basically the -1 is basically the one standard deviation than the normal. Okay, and when are you going to suspect the fragility fracture? Fragility fracture is where the velocity of the fall or velocity of the injury is pretty less and in disproportion to the amount of the fracture. Okay, so like here the fall, it is almost from the standing height, not from a like very height area or something. Whereas coming to the Z-score, as we discussed, it basically compares the populations. It involves the matching to the age, sex, and ethnicity as well. Like you'll basically be comparing the groups like men under the age of 50 or children. So in this case, it is always a T-score. So coming to the fourth question. So the take home from the previous question, as I told you, you need to read about the fractures, osteoporosis, and BMD interpretation, 3 of them. And coming to the next question, young lady, 33-year-old, presents to the clinic with acute stiffness and swelling of both her knees and ankles. Okay, these both are classified as large joints. At the same time, there is a painful rash on the legs. The ESR was around 92, elevated, and chest X-ray shows hilar lymphadenopathy. Okay, there's a joint involvement, predominantly the large joint involvement, elevated ESR, and X-ray showing a hilar lymphadenopathy. Which one of the following is the most likely conclusion? It's a pretty straightforward question for you in the exam. These questions you should not lose. So what is the answer for this? So to know this question, you need to identify the diagnosis, at the same time know the course of the disease as well. So what is the diagnosis here? You can either keep in the chat box, please, answers. Okay. So the diagnosis is basically acute sarcoidosis. These are the representative images of it. As you can see, these lesions are called as erythema nodosum. Okay. Predominantly they occur on the lower limbs, predominantly on the chin area. And if these erythema nodosum lesions are associated with a large joint involvement like shown here, here in the picture they're showing the ankle involvement, and in the X-ray you can see the hilar lymphadenopathy as well. So this is a syndrome of acute sarcoidosis. Okay, serum ACE levels, those things are corroborative findings for you. And acute sarcoidosis usually has a good outcome. It usually spontaneously resolves over 6 to 8 weeks. Okay, whereas here, as you can see, so this you can see the options here. To know this answer for these questions, you need to know that this is an acute sarcoidosis. And once you know that this is an acute sarcoidosis, obviously you need to read about acute sarcoidosis for it. And then you know that most of the acute sarcoidosis has a spontaneous improvement. Whereas the chronic features like renal failure, pulmonary fibrosis, these arthritis, all of them occur in a chronic sarcoidosis. Okay, where this discussion will be on a different terms. Are we clear here? So this is a very classical question to be asked in the exam, so don't miss it. Even in your MRCP part 2 and part 3 also, it is very important. So coming to the fifth question, you all should read the UK guidelines like NICE guidelines, NHS and NICE guidelines for all the common conditions. Okay, because most of the questions are framed based on the NICE guidelines. Here the question is, osteoarthritis can be treated with which one of the following interventions? So the question is as per the NICE guidelines. Only if you know the NICE guidelines, then you can answer this. So he has given 5 options. One is a chondroitin sulfate. Second is TENS, transcutaneous electrical nerve stimulation, acupuncture, intra-articular hyaluronic acid, and glucosamine hydronic acid. Okay, so as per the guidelines, which is the answer for the osteoarthritis treatment? So Dr. Mohammed Shah is answered TENS. Okay, very good. So the answer is correct. If you know the NICE guidelines, obviously you'll be knowing this answer. So NICE guidelines has various steps of management: behavioral change, exercise, weight loss, lifestyle changes, suitable footwear. All of them are a part of the management. Okay. And obviously osteoarthritis is a lifestyle disease, and where there's a degenerative disease of the joints. So if you can identify the comorbidities which are compounding these factors like obesity, like inappropriate walking hygiene, gait hygiene, all of them, you should always treat it or control it. Whereas the second line is like paracetamol and topical NSAID, they should be offered, especially for a knee and hand osteoarthritis, before considering an oral NSAIDs. Okay, and if these symptoms are not controlled with the above strategies, the next line will come like oral NSAIDs or COX-2 inhibitors. But remember that etanercept is not encouraged, and you should not use it in COX-2 inhibitors. Okay, this is the third line. And always, when you use an NSAID, you should always think about using a proton pump inhibitor as well. And when you're starting an NSAID, you should always start at the lowest effective dose and for the shortest period. And if the patient is already taking an aspirin, which has more or less the same kind of like a mechanism of action, the alternative analgesic can be used. And like this question which they have framed, the treatments which are not recommended. Okay, you need to remember that these are clearly stated in the guidelines that these are not recommended, like intra-articular hyaluronic acid, electroacupuncture, chondroitin or glucosamine products, which are very commonly being given by the orthopedicians. These, they were very clearly stated that these are not recommended. And what are the adjuvants which can be used? Opioid analgesics, topical capsaicin, intraarticular steroids, when you have a very florid joint manifestations, or external manifestations like application of heat bags, TENS. These all can be considered if the other strategies are ineffective. So manipulation, stretching, physiotherapy, these are usually helpful in the hip osteoarthritis. And again they may ask you what is your cutoffs for the referral to the joint surgeries. Okay, when you have a persistent symptoms and all the core treatments which are stated in the above lines are exhausted, then joint surgery may be contemplated. And if there's a clear history of mechanical locking, referral for the arthroscopic lavage and the debridement should be considered. Okay, so this is the basic line, and as you know, the tense is a part, and that is the answer.